Good afternoon, everybody out there. Thank you so much for coming in this busy afternoon. Today, my talk is rather special. It's a talk on big operations in my hospital. Iron Hospital is rather special because we are known to do big surgery, liver surgery, pancreas surgery. And today, my focus is on two very important topics, liver cancer and pancreatic cancer. Okay. Let me introduce myself. I am a consultant surgeon in Ireland Hospital for the last 26 years. My specialty is both liver and pancreas surgery. Of course, I do the usual gallbladder, the usual cancer of the breast, but what is important is that liver and pancreatic surgery is done in a very big way in my hospital. So the first topic on is on liver resection. Okay, the liver is the largest organ in a human body, 1.2 to 1.6 kilograms. Okay, it's the biggest organ, and at any time, about 30% of the blood flows through the liver. Liver resection is important because in our people, the Chinese people especially, liver cancer is very common for different reasons. You are aware that hepatitis B is endemic in the Chinese population, so liver cancer is quite common. Secondly, it's also done for secondaries to the liver. What do I mean by secondaries? That means you got cancer of the colon, cancer of the kidney, cancer of the stomach. If they spread to the liver, then the cancer inside this liver is called a secondary. Whereas liver cancer is a primary cancer. This is a secondary cancer. The important thing about secondary cancer is that if you can resect it, then a stage 4 cancer becomes almost a stage 1 cancer. And mind you, all these are major surgeries. The first, primary liver cancer. You can see a very huge cancer here on the right side. This is a computer scan. That's the backbone, that's the front, and that's the cancer. And you can see this normal left lobe. If there is enough normal tissue behind, we can remove this whole right lobe. And that is the cancer here. That's the right lobe with the gallbladder. Liver resection is not as complicated as before nowadays. It's a quite safe surgery, although it's complex. The mortality rate is today about 1 to 3%. All this because of recent advances in the equipment to remove cancer of the liver. We have the CUSA, we have the argon plasma, and all these are special tools. And today, understanding of the liver anatomy, the liver physiology is very important. During surgery, we do not infuse any fluid so that we keep the blood pressure and the CVP very low, so that when you cut the liver, there's hardly any bleeding. These are instruments to resect the liver. Here you can see me holding a special tool called a CUSA. You use ultrasonic waves to dissect the liver. The usual incision is called a J incision. Remember that the liver is a very huge organ. So unfortunately, because of its size, the scar sometimes very, very big scar so that we can control the blood vessels entering the liver. That's the liver. Okay. Essentially, there are five major steps in liver surgery. The first step is that after we've gone inside the abdomen, you can see the liver. We have to free those ligaments holding the liver. This is called freeing the liver. Okay, and after freeing the liver, we at the time of surgery, we do a scan of the liver because that's the most accurate time to assess the liver tissue and liver tumor. This is a scan. This is an ultrasound scan on the surface of the liver. You can see that sometimes we pick up very small lesions not seen on the computer scan. Okay. After that, we focus our attention to this area. This is called the porta of the liver. Okay. And here is when we do all the structure or the dissection. This is the common bile duct. This is the blood supply into the liver. That's the venous blood supply into the liver. We have to dissect and tie off the usual vessels on the right side. The right-sided vessels are dissected. On the left side, left vessels are dissected. So this is a series of slides. That's a gallbladder. First, we divide the gallbladder. Then we divide the vein. Then we divide the artery. Then we divide the artery. Once you have tied off the artery and the vein, something happens dramatically before our eyes. The blood supply to the right lobe gets cut off, and immediately you see a color change from the normal liver to a cyanosed liver. No more blood supply here. No more blood supply here. That's a gallbladder. Then the next step is really to divide the parenchyma of the liver. We can use different instruments. We can use a harmonic scalpel. We can use CUSA. We can use argon plasma. And this is a picture of a argon plasma resection. This is the cancer on the surface of the liver. We more or less chunk hole around the liver and take out this tumor. This tumor, very importantly, must come off with a very clear margin, 2 centimeter margin if possible. You notice that, okay, there's hardly any bleeding inside here. This cancer is on the right side, so a right liver resection called right hepatectomy is done. There's a cancer inside. There's a cancer site about 5 centimeters. This patient is still alive after 15 years. This is a bigger tumor. You can see this is a very, very nasty cancer occupying almost 2/3 of the right lobe. Very big tumor where we need to remove 70% of the liver. That's the cancer. That's the operative picture. Sorry. After the surgery, you can see that that is the part of the liver that's left behind. That's the stomach, you can see. That's the liver, the cancer removed. There's something very special about the liver. Once you remove the liver, over the next 1 to 2 months, it starts to grow back. The liver is the only organ in the human body that can regenerate. See, this is another picture. Cancer, tumor removed. What is left behind is this small area called the left lobe. Within 2 months, the left lobe gets bigger and bigger and bigger. That's called regeneration of the liver. Okay. Sometimes the tumor are not that big. Then we don't have to remove the whole left lobe or the whole right lobe. We can remove segments. the liver is divided into 8 segments. Okay, so this is a tumor over this segment. The tumor is here. We can remove just this segment. Okay, called segment 5 and segment 6. The tumor is here. Another tumor next to the gallbladder that's called segment 5. We just need to remove this segment. Okay, sometimes it's in the middle of the liver. It's quite hard to remove just this inside. We have to remove almost half the liver. Importantly, it is important to know that if you have something growing in the liver, you don't feel any pain at all until the liver tumor reaches the capsule. Then you feel tiredness, you feel loss of appetite, you don't feel strong, and you get some discomfort over the area of the tumor. On and off, the tumor can burst and start bleeding. That's when you have very severe pain. So the presentation of liver cancer is not the same for everyone. Okay? And importantly, you must diagnose it so that if it's small, we can remove it and achieve a cure. So small tumor, normal liver, you can be cured. Small tumor, we can resect it, you can get good results. But some cancers are very bad. Some cancers are already inside the liver, metastatic. These are small tumor, small metastases from the main primary. The Chinese have got to say, when that time we got cancer, they always ask me, doctor, is it a male cancer or a female cancer? What do they mean by this? Male cancer can be very big, but they don't metastasize. A female cancer can be small, but it can spread to elsewhere. You can see that this cancer is not a good cancer because it's irregular. The liver is cirrhotic. This is another cancer where you can see metastasis nearby. That's the cancer. You can see already inside the liver, there are metastases. Okay? This is a good liver cancer. Less than 5 centimeter, encapsulated. That means it doesn't have very vague margins. Okay, this is what is meant by a cirrhotic liver. The liver is hardened like a piece of wood, very hard. Okay, and of course you get liver cancer, you have to remove it with a 2 centimeter margin. Sometimes not every patient with cancer of the liver can be operated. In some people, when they come, the cancer inside has already spread within the liver substance. That's the main liver cancer. You can see these are metastatic nodules. Of course, this cannot be operated. If you are jaundiced, your eyes turn yellow, your urine becomes decolored, then your function of the liver is not that strong anymore and you cannot go for operation. Sometimes the cancer infiltrates big blood vessels in the liver. Inferior vena cava, once they get infiltrated the big blood vessels, you again cannot do surgery on the liver. Some cancers are very big. You can see here a CT scan, almost 70% inside is all cancer. Again, we can't do anything. Another example, hardly any liver tissue left here. That's the whole cancer. So again, these are not operable cases. That's part of the normal liver left behind, but not adequate, not enough liver. If we cannot remove the liver cancer, then of course the doctor will offer chemotherapy, special targeted therapy, or a procedure called transarterial chemoembolization. This is just to control the liver cancer. You will not get a cure. In Malaysia or elsewhere in the world, we don't do liver transplant for cancer of the liver. Like I say, sometimes the cancer comes from somewhere else, not from the liver. These are called secondaries. If the secondary goes to the liver, we can also resect. Okay? If we can resect the liver secondaries, we can achieve very good results. A stage 4 cancer becomes more or less, in inverted comma, stage 1. And there's still hope for cure. Show you one example of a patient of mine, an Indian patient, 40 years old, diagnosed with colon cancer and gone to the liver. Gone to the liver. So this is a stage 4 coronary cancer, and because he was still young, we were able to do synchronous. That means we were able to do both the liver resection and the colonic resection at the same time. This is called synchronous. See the date here, 1st of March 1999. That's 21 years ago. So through a very long incision, the colon cancer is removed. At the same time, the liver secondary on the right side is also removed. After the operation, he spent 2 days in the intensive care. Then, when he was well enough, he had very simple chemotherapy. So it is now more than 20 years now. He is normal in every aspect. His tumor markers are normal. His chest x-rays are normal. His liver has regenerated. Almost normal now. That's him just after the operation in 1999. That's him 3 years ago. He comes from KL to see me almost yearly, once a year. He has put on a lot of weight. Another example, 62 years old man with colon cancer, gone to the liver, spread to the liver. That's the right lobe. Then, during the follow-up, I told him, hey, friend, your left lobe is normal. And we can remove your diseased right lobe by removing almost 75% of it. Fortunately, he agreed, 70%, and this was removed. This is the picture, CT scan of the tumor before, and this is after. The diseased liver has been removed. And today is also well and healthy. So that's liver resection. I go on to the second part of my talk about pancreas. Every 10 years, one cancer will occupy the headline. 30 years ago, cancer of the lung. 20 years ago, cancer of the breast. 10 years ago, cancer of the colon. Today, these 10 years, cancer of the pancreas is on the increase. Okay? The operation I want to talk to you today is an operation called the Whipple operation. For years, it was called the king of operations. From 1935 to 1985, it's called the king of operations. Okay? This operation is done for cancer of the head of the pancreas. Okay, this is what I take out for cancer of the head of the pancreas. That's the pancreas called the head. That's part of the stomach. The gallbladder is attached. That's the duodenum, and that's the jejunum. This organ called the pancreas lies in the upper part of the body. It's a very slim and very important organ because there's a lot of lymphatics and a lot of nerves there. It's not a good cancer to have. Cancer of the body and head of pancreas are almost always lethal cancers. But the head of the pancreas is very special. You had a tumor at the head of pancreas, then something important happens. The bile duct from the liver, which drains bile, gets blocked. Okay, the tumor there, the bile duct gets blocked, and these patients present with jaundice. The eyes turn yellow, sometimes even orange. The urine is discolored because the tumor causes blockage of the bile duct. If the tumor doesn't cause blockage of the bile duct, then they will present in very non-specific symptoms, dyspepsia, and the doctors will not be aware these patients have cancer of the pancreas. A lot of them got very mild discomfort on the right side. The pain goes to the back. Of course, there's lost appetite, and importantly, there's a lot of weight loss. The operation for this cancer is very complex because we have to remove not only this region but almost the cancer here, but almost the whole region. We remove part of the stomach, the gallbladder, the head or pancreas, the duodenum, and the jejunum. And what is complicated about this operation is that after you remove it, we have to join back. We have to join the pancreas to the intestine. We have to join the bile duct to the intestine. We have to join the stomach to the intestine again. 3 anastomosis. This area is rather special because there's a lot of blood vessels, there's important artery and veins, which I've shown you earlier. To us surgeons, it's called tiger country. There can be a lot of bleeding. Okay, that's the pancreas divided. This is a very important vein to the liver. It's a big operation, so the scar is normally quite formidable. Okay, over the upper abdomen, just below the chest. Bilateral subcostal incision. These are pictures showing the operation. Okay. You can see a very important vein. That very important vein. That's a pancreas divided. This is the pancreas that's left behind. I already divided the pancreas. You can see the pancreatic duct where pancreatic enzymes flow through. Then we use a piece of intestine to join to the pancreatic duct. That's the most important anastomosis. Okay, that's where we join the pancreas to the jejunum. Secondly, we have to join the bile duct to the jejunum again. The results of Whipple operation is surprisingly very good nowadays. You used to have very high mortality, means 1 out of 3 die. Today, no. Maybe about 5%. Post-op morbidity is very acceptable. You see a big tumor in the region of the head of pancreas, there's a tumor. Okay, we've done an operation. I just show a patient of mine from Indonesia, 66 years old, jaundice, jaundice for about 4 months. The doctors in Indonesia suspected he may have cancer of the pancreas. Okay, they did ERCP, as very special test, but in Indonesia, they they put a stent through the tumor to relieve the jaundice. But the cancer is still there. He came over after 4 months. Fortunately, we're able to say that cancer hasn't spread and we still can do a Whipple operation. So this is the operation we done. That's the tumor in the head of the pancreas. There's a gallbladder, there's a stomach, that's the duodenum. Okay, remember he had a stent. You can see the stent, you can see the cancer here. Okay, the cancer here, that's a stent. Of course, we send the tissues for examination, confirm adenocarcinoma of the head or the pancreas, the H2B. Today he's well, but because of COVID-19 situation, he's not able to come, but he will come to see me as soon as the situation is over. So in summary, I have showed to you that liver resection, Whipple operation. In terms of time, I can show you, but I don't need to show up my other patients. For us, cancer is treating cancer is like treating the lalang in your garden. Suppose you have a patch of lalang in your nice garden. That lalang is a cancer. To get rid of the lalang, you must get your gardener to come and charcoal. He must charcoal the lalang, must charcoal the roots and all. Then, then, then chemotherapy is spraying weed killer, and radiotherapy is burning the area. Whatever cancer, if surgery can be done, the patient has a hope for cure. No surgery, no cure for solid cancer. Okay. Thank you so much for listening. Any questions? I'll be happy to answer. Question number 1. How can I detect pancreatic cancer early? This is a very, very difficult question because pancreatic cancer early, the symptoms are very non-specific. They present like gastritis. You see a doctor, usually your diagnosis have gastritis, dyspepsia, a bit of wind. And what is important is that when he treat you for a gastritis, you actually get better. When he give you medicine for gastritis, Motilium, maybe Lozan, maybe Nexium, you actually feel better. And when you see the patient, the doctor again 2 weeks later, hey doctor, I'm so much better. But on the 4th week, the symptoms comes back. Then, of course, the doctor will still think, okay, advise you on your diet, don't take salvage food, he gives stronger medicine, and again, you feel better. Until 2 months later, the pains now go to the back, you lose weight, and then you feel tired, maybe a bit of nausea, a bit of vomiting. This weight loss, pains going to the back, these are called alarm symptoms. That means something is not right. That is the time where now the doctors get worried. Okay, we better do a computer scan. Okay, and then you get a big tumor inside. So detect cancer early is very difficult unless you're jaundice. If you are jaundice, then the doctor must investigate. He must do at least a CT scan. He must do an MRI of the pancreas. Then you can pick up cancer early. So cancer of the head of pancreas is of better prognosis because the jaundice force the patient, force the doctor to investigate. Will my risk of diabetes increase after surgery? No. If you are not a diabetic, you will not become a diabetic. But if you are pre-diabetic, you may become a diabetic. The pancreas have got two functions. One, produce insulin. That means if I remove too much of your pancreas, you may end up with type 2, maybe a type 1 diabetes. The other function of the pancreas is equally important. It produces an enzyme for digestion. If your pancreas is really rotten, no more insulin production, no more enzyme production, then whatever you eat fat, you find you pass out the fat in your stools. This is called steatorrhea. You, you eat vegetables, the vegetables come out in your stools. Okay, so you will need special enzyme. The this question, how long will it take the liver to regenerate after surgery? The answer is that the liver almost the cells in the liver, the true cells, start regenerating from day 2, day 3. But there are other different types as well. There are the blood cells, there's a bile duct. Overall, it takes about 2 months for the liver to double its size again. Is there such a thing as being too old for liver resection or Whipple operation? At one time, we say 60 years old is old age. Today, WHO define old age as 80. Anyone below 80 is called middle age. Of course, age is just a number. A person at age 92 can be stronger and fitter than a person at age 60 with kidney failure, with stents in the heart. So, no, there's no such thing as being too old for resection. You must be fit and well. But before surgery, of course, you are assessed. You go for your heart checkup, you go for your lung checkup, you go for your kidney checkup. So if you're on stents, we stop the blood thinning medicine and we get a cardiac opinion whether you can go for the operation or not. Okay. I got a question here. What other alarming symptoms are there for liver cancer, pancreatic cancer? Those of you with hepatitis B, remember, although the doctors tell you, don't worry, you are a carrier. No, you have to stop worrying because the liver hepatitis B virus is there in you. Hepatitis B virus is today a DNA virus. Of course, you know about COVID-19, they say you mRNA vaccine. No, hepatitis B is a DNA virus. Cancer is a disease of DNA mutation. So whether you are once you are a carrier, your liver cells are affected. So you should go for every 4 to 6 months, get an ultrasound scan of your liver every 4 to 6 months. Most patients will go there first time, 4 months, 4 months. After the third or fourth visit, they say, what a waste of time. Then they start missing their scans. Okay, so That's where the cancer comes. The other test is called the blood test called AFP, alpha fetoprotein. The normal is below 8 today. It's a good cancer marker because most patients come up to see you with AFP quite high, and then they go for a scan and then pick up the liver cancer. But not everybody have got raised AFP. About 10 to 15% of liver cancers do not have raised AFP. So it's best to go for your regular abdominal ultrasound to scan the liver to pick up early cancer of the liver. Okay, one question just came in. Okay. When should I consider surgery instead of other therapy? Cancer of the pancreas, cancer of the liver are what we call solid cancers. Leukemia is a liquid cancer. Solid cancer, one thing is very special that you need to remove the cancer. You can go for chemotherapy, maybe to shrink the tumor, make it smaller, make it easier to remove, but you need to remove the cancer to achieve cure. I told you earlier before, it's like a patch of lalang in your garden. You can burn the lalang. The roots are there. After 4 or 5 months, the lalang will spring back into action. Full everywhere is lalang. You can spray the lalang with weed killer. The lalang will die, but the roots are still there. Okay, so the only way to get rid of a patch of lalang is to get the gardener, hey kawan, cangkul lalang ini dah, cangkul. So must cangkul, especially the akar, the roots, and cangkul some distance away so you get a safe margin. And then of course we analyze the lalang, and then the gardener will tell you, hey boss, kita spray dah, okay, weed killer every month, once every month for 6 months. That's chemotherapy. So certain areas in your garden we cannot jangkau because maybe the pipes are there, the electrical lines are there. Then, hey doctor, we burn this area. That's radiotherapy. So we either cut, which is jangkauing, you either spray, that's with chemotherapy, or you burn, that's radiotherapy. Any more questions? Okay, so thank you very much. Thank you very much.